Welcome to the Homegrown Heart Podcast, every Friday at 7 a.m. Mountain Standard Time, with your host, Dr. Amanda Ryan, DO, MBA, interventional cardiologist, and an expert in her field. This week's topic, evaluation prior to having surgery. Please welcome our host, Dr. Amanda Ryan.
Good morning, Eddy County and surrounding areas, and Illinois, Florida, all of our people out there listening. I'm Dr. Amanda Ryan, your friendly interventional cardiologist. We're back in studio. Last week had a great episode on aortic awareness and dissections, and I think that was really good. And then coming out this morning again is our being truly married, the emotional, physical, and psychological toll that call really takes on physicians. I think you'll definitely get some insight into listening to that. So again, just want to do a shout out to our producer, Danny Fletcher, who we were just discussing the Mayor's Energy Summit here in Carlsbad, New Mexico, which is an amazing business event. And so look out for information about that. But he was the MC and has been for years, has chaired that committee, and now is able to focus on his own podcast quite a bit, This, That, or the Other. So be sure to tune into that as well. I'm going to encourage you both on Danny's and mine, again, the Homegrown Heart, to go ahead and subscribe. The more subscribers we get, the better that is for our overall futures. So today I'm going to talk a little bit about perioperative risk stratification. And that's kind of a fancy word, again, cardiac clearance. So if you've been a patient of mine or anyone's that needed a surgical procedure, and there are differences in emergency surgical procedures and non-emergency and quote-unquote elective. So let's talk a little bit about the different types of urgencies of a surgical procedure. If you have had an emergency, if you've had a gunshot wound to your abdomen, that's an emergency and you're going to go to the operating room, and it does not matter what the cardiologist or anyone else would say or about your risk at that minute, because your risk of imminent death is higher than any potential cardiac risk to you. However, I have been called into the operating room before as a cardiologist in an emergency situation for gunshot wounds or many other things to say, hey, this person's losing a lot of blood, their blood pressure's dropping, we're doing this, we're doing that. Is there anything else you can think of that can help decrease this person's risk of a worse outcome, be that cardiac or otherwise? So sometimes maybe you do have a blockage and we don't really know about it. And if you went to the operating room in a stable situation and you did it, let's say you were going to have your gallbladder out, that is what we're going to call elective or urgent, not emergent typically. Meaning you're having gallbladder attacks, which could mean right upper quadrant pain, nausea, problems with your stool, those sort of symptoms. It's gotten to a point where your surgeon is recommending that you get your gallbladder taken out. Now, there are stones that can get stuck places and become quote unquote emergent. So, in 20, 30 minutes, I won't sort out all of that, but I'm just going to say a relatively semi-elective gallbladder procedure. Let's say you have an 80% blockage in your heart and you don't know about that. So your doctor may send you to me to say, hey, what kind of risk does this person have for having a problem during gallbladder surgery? There's two things that I'm really trying to think about for this quote unquote preoperative risk stratification or cardiac clearance, quote unquote. What is the risk of the procedure, usually? And what are you as a person? What are your risks? So a gallbladder surgery is relatively low or moderate. And we kind of we're going to classify things as low, moderate, or high risk. And we're going to classify people and your risk as low, medium, or high risk, basically. So a gallbladder is relatively low or medium risk surgery. Then there's you. You have diabetes. I'm going to pretend this is you. You're 60. You have diabetes. you have a strong family history of heart disease, you smoke regularly, and I get a baseline EKG on you, which is required within 30 days of surgery 99% of the time, and it looks abnormal. So then when I see you and I talk to you, you're like, no, but I don't have any chest pain. I'm not really that short of breath. Of course, I don't walk a lot. I don't. So that's kind of one of those, you have a lot of risk factors. You're kind of a high risk person, a medium risk person, and a low to medium risk surgery. So sometimes people think, I tell people, I'm not just wash a wand over you and say, you're cleared for surgery. Again, I'm not a higher being. I'm not God. I don't feel as though it's my job to say that you're either cleared or you're not cleared. It is my job to risk stratify you for your surgeon or who's ever doing your procedure and your own knowledge, and then we decide if we need any more testing done, if we feel you're safe to have the procedure, or if the procedure is not a true emergency, you probably shouldn't have it. So that patient scenario I just gave you, probably I would say, doing a good stress test, putting you on a treadmill and getting you up to peak exercise and checking an echocardiogram on your heart so I can make sure that all your walls are pumping well and that you don't have any signs of a blockage would probably be a good idea before going for this, semi-elective gallbladder surgery. Since I said that the patient had an 80% blockage, stress tests are designed to pick up 60-70% blockages or more. So probably I would have picked up that blockage. Now, then probably would have proceeded to an angiogram. Now, if you get a stent put in this 80% blockage, that used to be you had to take antiplatelet drugs like aspirin and Plavix for at least 1 year if you got a drug-eluting stent. We're thinking now that 3 months, 6 months, or even 3 months might be sufficient for those, so then maybe you could have your procedure then. But these are all the kind of things that I'm thinking about when you come to my office or I'm asked to see someone in the hospital to help decide what their risk of surgery is. I'm going to tell you there are 4 things when I'm training a new nurse practitioner, a new medical assistant, a new nurse in my practice that we really need to look for cardiac risk stratification. Number 1, if you have critical aortic stenosis, again, your aortic valve, I tell people, kind of looks like a reverse Mercedes-Benz sign. It looks like this. It's inside your heart. It's what your heart's arteries come off of. If that gets very tight, like those leaflets are not opening in the way they need to, and surgically you get dehydrated or your blood pressure drops, that can make the aortic stenosis worse and it can have a fatal outcome. So if you have a very tight aortic valve, so if we listen and say, we hear a murmur, we probably need to get an echo and assess how much these valves might be causing a problem. If you are actively having a heart attack and you're like, well, why would they be asking you for clearance? Okay, not in the office, accurate. But in the hospital, sometimes this patient is bleeding and they're actively having a heart attack, but they need to have a scope. They're bleeding from their GI tract, but we need to scope them. But someone's like, but we need you to see what their heart arteries look like because they're having a heart attack at the same time. That can be a very difficult situation because most medicines I give in the cardiac catheterization lab are blood thinners. So they are going to make bleeding much worse. So then you're like, oh gosh. So sometimes we might even have to just look. It depends on how bad you're bleeding. Emergency equals emergency. We'll transfuse blood. I'll be on standby to be supportive, but sometimes we have to do what we have to do. If you're bleeding but you're still quote unquote stable, I might look in the cath lab and figure out exactly what is the situation. Then I can tell the anesthesiologist as well as the surgeon better information about what your immediate risk is. So then active congestive heart failure. If you are fluid overloaded, you have a reduced ejection fraction. And again, I think I've said before, the way we're classifying heart failure has changed over the years, so many different terms. HFrEF and HFrEF are our current heart failure with a normal ejection fraction or preserved, and heart failure with a reduced ejection fraction. So again, 50 to 55 is a normal ejection fraction. That's what your blood is going to pump out. Your heart's going to pump out 50 to 55% of the blood every time. Stroke volume times heart rate, that's going to give you your ejection fraction. Heart failure, if you have an ejection fraction that's less than 35%, definitely is going to be putting you in that heart failure reduced ejection fraction category. Versus if your ejection fraction is 50 to 55 and you still got fluid overloaded at some point, or you get fluid overloaded, we would put you into what's called a diastolic heart failure category, a preserved ejection fraction. There's some different treatment options depending on whether your heart has a preserved or reduced ejection fraction. But with that, the idea is that if you have a reduced ejection fraction and you are actively fluid overloaded, swelling in your legs, fluid in your lungs, short of breath, we should not be sending you for surgery if we don't have to. So again, critical aortic stenosis, active MI, and active CHF. Those are reasons that I'm going to say you just should not have surgery unless it's absolutely emergency. So again, are you low, medium, or high risk? And is your surgical procedure low, medium, or high risk? Medium is also referred to as intermediate. When you're risk stratifying people, though, I do think even sometimes if I say, well, you probably are okay to have surgery, but you are a little bit in the high risk category. Let's say your ejection fraction is 25 to 30%. You have a defibrillator. You've been doing well. You're on what we call, again, GDMT. That's maximized guideline-directed medical therapy. So your heart failure is being treated with good medicines. You're not being short of breath. And your classification of heart failure right now is kind of like a 2. You're probably okay to have surgery, but you still might be what we consider in that moderate to high risk range. High risk chance of having a complication during surgery, though, might mean 20% chance of having a problem. I think we've gotten to a point where we kind of feel like high risk, like, oh, that must be like a 90% chance that I'm going to die on the table. No. It means the average person, low risk, might have a 1 to 2% chance of having a problem on the table. A moderate risk person has somewhere between a 3 and 10 to 15% chance. A high risk person has a 15 to 20% or higher chance of having a significant problem. That would be 1 out of 5. That's still pretty high, but that means 4 out of 5 chance that you do get through the surgery and do not have a major cardiovascular complication. So there's just a lot of different things to think about. I think a very important factor here, again, is remembering the value of informed consent. As long as the patient, the surgeon, the anesthesiologist, the family, we need to understand the situation. That's often my job in my office, discussing with people their surgical risk for certain things. I had a lady just yesterday. She's a moderate risk candidate for a complication around surgery. She's having a bladder stimulator and kind of a fancy. In the urogynecology world, there's a lot of advancing procedures all the time. So I don't know the exact details of this procedure she was going to have. But it was done for recurrent urinary leaking and incontinence. Now again, women as we age have had children especially, but it can happen. But sometimes your bladder just doesn't tighten up the way that you want it to. And again, if you sneeze, cough, or otherwise, sometimes you have leakage of urine. That can be pretty embarrassing, and it's a lot to deal with. So somebody might choose to accept a moderate or even high risk that they are a moderate or high risk person to have a procedure that's kind of moderate risk, but is going to really improve their quality of life. And I mean, personally, I'm probably making that same decision in that instance. And I didn't have a reason to tell the patient she totally shouldn't do it, but I just, looking at her, knowing her history, thinking about it, I wasn't super excited for her to have a kind of elective procedure. On the same token, I listened to her and I heard her frustrations about her situation and what was happening to her, how it was affecting her work life, which she was still actively working, and her social life. And I was kind of like, yeah, I understand. So sometimes it's just about making sure that our patients have true informed consent. If you understand the risks and benefits, the surgeon and anesthesiologist feel comfortable, then I'm available. I always tell people, if you have a problem during or after surgery, they can definitely call me. Again, just like our foundation partners in Heart Health, I really strive to be the kind of physician that forms partnerships with my other providers, partnerships with my patients, partnerships with the community, partnerships with the hospitals and large corporate systems in healthcare, meaning that I'm not here to just say, yes, you do this, no, you don't do that. Again, this paternalistic, I tell you what to do, I say, and everybody does exactly what I say or you say. That's not really how it's meant to be, in my opinion. Collaboration is the key to any situation. It's definitely the key to appropriate health care. I do believe there needs to be a shift in healthcare in America. I had a great conversation with Leslie Akram, who is my best friend from medical school. Last week, we were catching up. Her brilliant son is doing his college tours, and he was then doing something, and I probably hadn't gotten to talk to her in 6 or 9 months. She's a busy OBGYN up in Minneapolis. She called me and was asking me how the surgical center was going and how life was going, and oh God, we were lamenting on some of the realities of modern healthcare, the prices of some things, the overhead, the staffing, just so many different things. And she said, I don't know, Amanda, sometimes I do think, we're headed for crisis. And she grew up in, north of Minneapolis in Minnesota, practices near her hometown, is just an amazing provider, making a big difference in semi-rural Minnesota, just like we are out here. And it just it hurts my heart to think about where healthcare is going to be in 20 to 30 years if we really aren't able to affect some change. And it's interesting, I've been following some of the CVS stuff too and what's happening with their, a foray into healthcare on the urgent care side and infusion therapies and stuff. And I'm reminded that the complexities of healthcare are just, and the relationships in corporate America and how those are really playing a role in whether a venture can succeed or whether they can't, and the different options. It's just, again, to the predominantly male administrators and physicians who said I was a little bit naive getting this surgical center going, you're right, I was a little bit naive. And not for the reasons that you might have thought I was naive, but every day my eyes are opened a little bit more to the corporate healthcare realities. And sometimes I wish I could go back and shut my eyes, but I can't. So what I can do is work within the system and try to push forward with change, no matter how small it might be. And with your support, we will continue to make slow progress. And that's kind of how I feel at this point with the project. All right. So again, back to risk stratifying, and I've showed a couple different slides today too of we need surgery, we need to have risk stratification. We need to know if the surgery is cardiac or non-cardiac, or cardiovascular or non-cardiovascular. Because procedures, open heart surgery, procedures on our aorta, on our carotid arteries, those are going to be some of the higher risk surgeries. Transplants, all of those things are going to be high risk surgeries. A lot of the high risk nature of it is because you're involving the vascular system. It's also because of the shifts in blood volume and blood pressure are very major in a lot of those procedures. And so those are really important for us to try to get to the root of, are you low, medium, or high risk? And is there anything we can do? Again, it used to be beta blockers for everybody, risk stratify someone before surgery, put them on a beta blocker. And there are times that's still the right answer. But again, you have to individualize care. There are a lot of guidelines in medicine, and there's a million guidelines in cardiology. There is an American Heart Association, American College of Cardiology, preoperative risk stratification guideline, and we do our very best to follow that. However, there's always room for each, and it'll say in any guideline, there is room for each unique patient. So I think the reality is the most important thing is for your physician or cardiologist and you, prior to having a procedure, get an opportunity to discuss the risks of it. That includes if you're in the hospital and you need a semi-emergent urgent procedure, or if you are in the outpatient setting and you need more of an elective type procedure done. Now, true complete emergencies, again, you tear your aorta, you have an aortic dissection, which unfortunately somebody did yesterday. They did get to the next place, higher level of service, so that they could see if they could fix that dissection. But that's a high-risk person having a high-risk procedure, but it's life-threatening situation, so there really is no option. So I think that sums it up for perioperative risk stratification, and whether you are low, medium, or high risk, and whether your procedure is low, medium, or high risk. Maybe one last thing to add is, holding your blood thinners or your aspirin and Plavix before surgery, your warfarin, your Xarelto, or your Eliquis. Depends on why you take it. Is it for stents? Is it because you've had a stroke? Is it for blood clots? Is it for atrial fibrillation? There's different reasons why people take different antiplatelet drugs and different anticoagulation. How long ago did you have a blood clot? How long ago did you have a stent? Do you have several? Did you just have one? All of those things are really playing a role. So it's a pretty complex process. So sometimes people come into my office like, I just want my knee surgery done. I don't want you asking me questions. I just want you to sign off on this. This is what the orthopedic doctor said I had to do. Oh, well, I smoke 2 packs a day and I don't walk regularly because my knee hurts. And so I don't have chest pain because I don't do anything. And my mom died of a heart attack at 70. And my diabetes is not well controlled, but I want you to say, clear me for surgery, say it's fine. And I'm like, well, we're gonna have to work through that a little more because your risk of surgery is pretty high. And while your knee may really be bothering you, that does not make it an emergency for you to go have your knee done. So sometimes we have to take a step back and see if there are some things we can change prior to sending you through the knee surgery. I want people to get the procedures they need to have done. I want quality of lives to improve. However, we've got to do it as safely as possible. So I think important to remember that from the cardiology practice side of things, we are here to help give you information about your risk of surgery and to do any testing or any medicine changes or anything that we can do to better control of your blood pressure, whatever is necessary to lower your risk before you do in fact have a surgical procedure. Have a great week, and we will see you next week where the topics that vary in cardiology and medicine will continue to get more and more interesting as we go. Thank you.